So with all those things, let's take a look at a few of the cases that we talked about at the beginning. So of course, before we do that, we'll repeat the key points. Point-of-care ultrasound is going to make you more accurate at diagnosing these skin and soft tissue lesions. Always scan deeper in the tissue than you think you need to be and go from normal tissue through the area of concern to normal tissue again. Make sure you know what fluid's going to look like, air, and other things that you may encounter. A lot of the fluid is not well circumscribed. It can be complex and loculated. Always apply color before you place a blade into any lesion. So here was the first case we talked about. 2-month-old, looked like cellulitis on the buttocks. We weren't 100% sure. Had to make decisions of does it need an IND or sedation, and how complex is this case going to get? And with ultrasound, able to quickly identify there's a complex loculated abscess in this lesion, so we probably need to take steps to ensure drainage, whether that's a sedation here at the bedside or do we need to arrange an OR case. That's a whole different discussion. But we can't just treat this with antibiotics and think it's going to get better. And these are some of those questions that we kind of alluded to earlier. And in this case, we decided this patient needed to be sedated, have an IND, and then admitted for IV antibiotics. So that's what we did. Next case, the 35-year-old male. This is back from my residency when I was asked to go ahead and just drain this abscess in this guy's groin. And it turns out, luckily, looked with ultrasound and we decided, let's not drain this thing. And then with further history, we learned that this patient was an IV drug user, had been using their groin, didn't come forward with any of that information to begin with, and they had caused their own pseudoaneurysm. This was not an iatrogenic case. Obviously sought vascular consult, and they had to undergo repair this thing, this pseudoaneurysm. Not to get too geeked out on the vasculature, but if you look, we've got color on here. We've got the classic kind of yin-yang back and forth flow coming in and out. Here's the source femoral artery that patient had hit, and that big pseudoaneurysm that's just leaking blood flow into there. Third case here, so this patient points to their arm and says, I got this red swollen area here, and what is it? And you think maybe it's cellulitis, maybe it's something else, and you pretty quickly look and you see this oniony circumscribed venous thrombosis, and if you follow it far enough, you'll see it eventually turn into normal vein to help you even more confidently diagnose this as a superficial venous thrombophlebitis. And since it's superficial, it didn't track into their deep veins anywhere, you can just treat this superficially and give the patient reassurance. There we go, superficial phlebitis. We're just going to do supportive care, but more confidently, more accurately, because we used point-of-care ultrasound. And then our next case, this 48-year-old male who presents with redness to the groin area. This is a person who's never really gone to the doctor, so they don't really have any real known medical history. They don't look terribly sick. You palpate the area, you think maybe there's an abscess, maybe you're going to drain it at the bedside. Luckily, you go ahead and you decide to take a look and realize there's a bunch of gas in this tissue. All these white things are bubbles, this streaking artifact. This is air in the tissue, and this is a necrotizing infection. So you drastically change course in your plan. Don't stick a knife in there. Start resuscitating, do a big workup on this patient, start broad spectrum antibiotics, and get a surgical evaluation promptly. Gas in the tissue, aggressive treatment, surgical consult. This is a necrotizing skin infection. And the last case we did here, so this was a 4-year-old with a non-healing foot wound, been seen multiple times, doing antibiotics, not getting better. And so you think, well, let me take a look at this thing and see what's going on. What you see here is it's like some kind of a foreign body. It's got fluid around it. And you take some other views and you realize this kid had stepped on a splinter. And they'd had x-rays before, but they didn't show it because wood doesn't show up on x-ray. So you find that this kid has a splinter in their foot. You're probably not going to be able to get that out at the bedside, but you identify it, you continue antibiotics, get prompt follow-up so they can have surgical removal. And this kid finally, after over a month of antibiotics and kind of misdiagnosis, was able to have this removed within a week, was doing great and walking around again. So again, ultrasound, this would have been nice to apply it early in this patient's care, but at least finally by incorporating it into this patient's care, we're able to make an accurate diagnosis and give proper care to this patient. Things that we've kind of mentioned already, I like to say them again because I think they're important. Place your probe next to the wound or next to the lesion where the tissue is normal, and then scan all the way through the lesion or area of concern until you get to normal tissue again. And make sure you have adequate depth to see all the borders of whatever's down there. Apply color to anything you see, that especially if you're thinking about cutting into it, but also to see if maybe it's a lymph node or something else. Don't miss fluid because it's layered or complex. Remember, lots of abscesses are not round pockets. They're complex, they're loculated, and sometimes you'll see a little lesion and it'll track deeper than you think. So make sure you see the full depth and the posterior borders of any lesion or structure that you're concerned about. Don't miss air in the tissue, so hopefully with some of these images you won't miss air, you'll recognize it and know how to manage that. And like I said before, and over, apply color before you decide to IND anything. And last one, I'm going to give you a little bonus case here and give you a little bit more on how ultrasound can help you tailor the management specifically to these patients. So this is a 17-year-old who came in with pain above the gluteal cleft. no real fevers, no injuries, and you don't really see anything externally. The patient just says, it really hurts right here, and they put their finger right back on their buttocks. You don't see anything on exam, so you just place the probe there, right where they point their finger, and they are tender when you press there. And what you see, nothing on the skin, but when you look with ultrasound, you see this well-circumscribed lesion. Looks like it's probably fluid because it's got posterior acoustic enhancement, and because it's nice and well-circumscribed, you decide, what are you going to do? Could you treat with antibiotics? Are you going to IND it? Obviously, I didn't show this, but look with color first. Make sure it's not some weird vascular abnormality. And we decide it's not, so there's no flow with color, and we think, well, it's nice and round. This is a good candidate for just a simple aspiration, so probably a more painless and easier procedure for the patient, probably easier for you as the provider as well. Give them antibiotics after you do a simple aspiration on it, and this patient did well. What I want to point out here is just how by using ultrasound and seeing, one, there's a lesion here that I probably didn't even suspect on exam where I didn't see anything on their skin, so it helped us make that diagnosis, but also we see it's pretty small, it's pretty round and well circumscribed, pretty accessible to a simple aspiration, and I don't have to do a bigger incision and drainage, which again makes your life easier, makes the patient's life easier and less painful, and just helps us give a more tailored care plan to this patient. So that's pretty much everything I've got to say with point of care ultrasound for skin and soft tissue infections or lesions. I'll just repeat these key points one more time. If you incorporate point of care ultrasound into the diagnosis and care of these patients, it's going to make you more accurate at identifying whether it's cellulitis, whether it's an abscess, whether it's anything else with air in there. Going to give you better decisions. When you're scanning, make sure you go, one, deeply enough, probably deeper than you think. If there's any lesion you see, make sure you see the deep or posterior borders. Take that probe from normal through the area of concern to normal again. I want you to recognize what fluid looks like and don't miss it because it's complex or loculated. I want you to recognize what air looks like, because if you can't explain why the air's there, then that's going to change how you're going to manage that case. And all the other things we talked about, like hernias and lymph nodes and things like that, vascular structures, and always apply color before you cut. That's everything about skin and soft tissue point of care ultrasound. I hope you found it helpful, and we'll see you next time. Thanks a lot.